everyone. My name is Roopa Ram, and I work at the University of Arkansas. And I do a lot of body imaging and MSK as well. And always good to share good cases with you guys. Certainly learn a lot. Sitting at home, it's a good mental exercise to work through these cases. So, can everybody see my screen? Okay.
Yeah.
Okay.
Yep.
Okay. So, just a little bit of history. So this was a 27-year-old patient who presented to the ER with 3 weeks of abdominal pain. She also complained of change in bowel movements for the past year or so. She said she would only have a bowel movement every other day compared to previously when they used to be regular 1 year ago. And physical exam, just diffuse abdominal tenderness, and review of labs was significant for anemia. Her hemoglobin was 8, normal white count, normal SED rate, CRP. So as always, CT scan has always all the answers. So here's her CT. And if there are any trainees in the audience, just always remember to look at your scout radiographs. So the thumbnail of the scout here shows dilated small bowel loops. So we're thinking of some bowel problem, especially given her history. So as we scroll through the CT, some trace perihepatic fluid, beginning to see those dilated small bowel loops, lots of air fluid levels, fecalization. Young patient with bowel issues, appendix is always good to see. So here's her appendix. It's always hardest to find the appendix when you need to, it seems like. And then here are some more dilated bowel loops, bladder, and we're done. I'm going to stop at this image. Any thoughts? Anybody wants to chime in? So looking at this area here.
It looks like there's almost like a mass, maybe
Right.
affiliated with the small bowel in the right lower quadrant. Yep, a
Right.
mass, a new also.
Right. So this was appendix. So this was around the IC valve area. And then, which makes sense that there is something obstructing at the IC valve. Let me run the colon for you just to complete our bowel. So
Roopa,
here
we also have some more guesses of carcinoid or neuroendocrine tumor, or maybe the nodal metastasis from there.
Okay, all good thoughts. So here's transverse colon, collapsed. Here's ascending. Little bit of wall thickening, but the colon is mostly collapsed. So everything makes sense that whatever this is at the IC valve area with upstream small bowel obstruction. And then I'm going to scroll some more down through the pelvis for any additional thoughts.
Looks like the ovaries are abnormal.
Okay. Rightly said. So the endometrium had some fluid, and then both adnexae had these multilobulated cystic structures. And when we looked carefully at this left one, it almost looked like some of them were septations, almost like a tube. And then when you change the windows to a narrow window setting, some of these had more complex contents than just simple fluid, and they were in the 25 to 30 ounce field. So young female, she could have hemorrhagic cysts, other bilateral ovarian lesions of some sort. And when we look at ovaries, always also by habit look at the omentum and other structures, which all looked clean. There was no regional lymphadenopathy, there was no ascites, there were no effusions, no nodularity anywhere. They actually ran a CA125 on her, which came back at 85. Upper limit of normal is up to 25 based on this reference standard.
Roopa, so we also have guesses of METs. So METs to the ovary, Krukenberg METs to the ovary from possibly a small bowel mass.
Okay, so all good thoughts. Didn't find any, at least in the imaged part of the abdomen pelvis, things we would look for sources of Krukenberg would be mucinous tumors, primarily appendix, sometimes the colon. The appendix in this case looked okay. What we saw of the breast didn't show any masses. We caught just the bottom end. Stomach didn't show any masses, which those would be common suspects for a mucinous primary in the abdomen. But of course, this workup would not be complete. So regardless, she got a surgical consult because she was obstructed, she was anemic, she had had complaints for nearly a year. So and then after surgery consult, we decided to do just conservative for now, just to watch what she did. So they did NG decompression, they did a small bowel follow through, and even 4 days after small bowel follow through, her contrast never made it past the TI into the colon. So this became a high grade obstruction and she went to the OR. Any other guesses before we go through what the operative findings showed?
Yes, endometriomas and related
Okay.
to an intussusception. Alina, we've got more people also saying endometriosis.
Okay. I think that's a great thought too.
TB
So
can also hit the ileocecal valve.
sure. That's so travel history, if she's from an endemic place, all that matters. Some of the other differentials we also thought of were like an unusual presentation of Crohn's, more like a mass-like variant, like an inflammatory mass from a first-time presentation of Crohn's. But that wouldn't tie up the ovarian findings unless the ovary was tied to some old PID with a complex hydrosalpinx on one side and some cysts on the other side. And then unusual but cecal masses other than primary malignancies would also be inflammatory pseudotumors, which have been reported in the cecum. And then a very, very unusual form of, say, something like lymphoma, but then no other nodes or anything else, no aneurysmal bowel dilatation, but those were other thoughts. Um, and then upon surgery, she was found to have, so the surgeons and the GYNs did a combined approach on this. They had GYN as a backup. So the surgeons removed what they called a soft tissue mass. She actually got a terminal ileal resection, a partial right hemicolectomy, and resection of that entire ileocecal region. And then when the GYNs walked in on the case, they said both ovaries look very abnormal. And the minute they looked at the ovaries in their op note, they described these as chocolate cysts. So they straightforward at surgery said bilateral ovarian chocolate cysts were seen. And then final path review of this ileocecal mass also confirmed this to be endometriosis. So it's a good example to remember that endometriosis is a great mimicker. We've seen the more common variant of endometriosis on the serosal deposits on the rectosigmoid most of the times. But bowel endometriosis, the uncommon variant is the ileocecal junction one. It's less than 10% of cases. And there have been case reports where they report intussusceptions secondary to a cecal endometrioma, volvulus secondary to a cecal endometrioma. And if it happens to be at the mouth of where the appendix opens, appendicitis from an endometrioma. I think what threw us off in this case was the lack of a good history previously. She did not have any cyclical symptoms previously or abnormal menstrual history, presented for the first time with anemia and bowel related symptoms. But good.
Also, it looks like such a big mass in the
It
ileocecal. I
does.
didn't know that endometriosis could look
Yeah, and it's
that.
very solid and ugly looking.
Yeah.
And I'll show you the coronal if that helps. So very mass-like form, very deceptive.
Yeah, great case.
Yeah. But at surgery, they did find extensive adhesions. And interestingly, they said the serosal surface of the sigmoid and rectum and all other common places where you would find endometriomas were all clear. So bilateral adnexal masses, and like we always say when we see a hematosalpinx, bilateral hematosalpinges, that's a presumptive sign of endometriosis anyway. So using narrow window settings, putting together the ovarian findings with a small bowel finding just makes for a good case.
Awesome. Thank you.
All right.